I think as Dr. Ip said, there is a lot of research going on to find out even better treatment. One of the thing is that macular degeneration is not going to go away for a near future because we are living longer. The more longer you live, the higher is the risk for macular degeneration. And again, as Dr. Stevens says, family history, genes, and all that, there is a lot of research going on. And to speak about that, we have a little change in the program. Dr. Barb Blodi, who is the professor of ophthalmology, will speak to that.
Good morning. Thank you all for being here and attending our session this morning. I do want to highlight the fact that the afternoon session will be different this year. We will have a session on diabetic eye disease. You are all welcome to stay, but you don't have to. There will be some overlap in the discussions because of patient advocacy as well as low vision. So there is some overlap in the two sections, but we're really happy that you're here. If I could have the first slide, I'll talk a bit about current eye research nationally and within the Department of Ophthalmology. So again, as you've heard, the macular degeneration is primarily the dry type, and less than 10% will develop the wet. It is the same disease. I think we try to separate them because that helps us when we see our patients, but really it is the same disease because all patients, all people with macular degeneration start out with dry. So treatments for dry macular degeneration, we really have no way to stop the onset of this condition. We have no way to prevent it, as Dr. Stevens mentioned. But we do have some treatment that can reduce the risk of going from dry to wet. Just want to show of hands, how many of you are currently taking some eye vitamins, the AREDS formula? Yes, great. So thank you, and I appreciate that you all are doing that. That's really, for the dry, the most important thing that we can do. We can't change our genes. We can also change our lifestyle, and Julie Maris will be talking about that as we look at nutritional factors that may help us as a prevention. So many years ago, there was the AREDS trial. It started in the late 1990s, and it tested this crazy idea, and I thought it was a crazy idea, to look at vitamins for the eye. I thought, this is not going to work. But there were scientists much smarter than me that realized that these high doses of vitamins could serve as antioxidants. So these vitamins are not used as our typical once-a-day multivitamins, but they're used in a different way. They're strong antioxidants, which can help preserve cell function. Those vitamins, the combination is beta-carotene, vitamin C, vitamin E, zinc, and copper. So many of you are familiar with that combination. Beta-carotene is a carotenoid, and you'll hear more about that again from Julie Maris, but carotenoids are pigments, and they're useful in our vision. Most recently, however, we've had the second AREDS study, so AREDS2, and the results of that came out last year, and I'll spend a little bit of time talking about AREDS2. The AREDS formula, again, has been in use for 10 years, where patients with the dry type have been encouraged to use this AREDS formula vitamin. Turns out it's pretty well tolerated. Almost everyone can take that medication, doesn't have side effects, or the supplement, they don't have side effects, and they can take it in conjunction with a regular multivitamin as well as their regular medications, their daily medications. So the AREDS2 study, again, just ended last year, but in this study, all the participants in the study were already taking that original AREDS formula. So they were given those vitamins as part of the study. That meant they all had macular degeneration. So the study included only patients that had macular degeneration, and they had one eye that had to have never had wet, that never developed the wet form. There were 4,500 people enrolled in this country, and we were here at the University of Wisconsin, one of the sites, following patients. I know that many of you participated in that trial. So patients were asked to come in once a year for an examination over 5 years of time. And the question was to look at new supplements. And the two major questions was to look at lutein. Lutein is similar to beta-carotene. It's in that family of carotenoids. Lutein and zeaxanthin, its sister compound, were tested to see if that would help in addition to this original formula. The other supplement that was being tested, this is a mouthful, the polyunsaturated fatty acids. You can think of that as fish oil. Whether those two, lutein and fish oil, could lower the risk of developing the advanced or wet form of macular degeneration. So could it help more than the original AREDS formula? And these dietary supplements were given at fairly high doses in the study. Again, the lutein and zeaxanthin, they kind of come together, were given at a dose of 12 milligrams, 10 plus 2, and that was given every day to a certain group of patients. And then these long-chain polyunsaturated fatty acids, omega-3s, were also given at a dose of 1 gram. That's, again, a fairly high dose. In this study, though, we didn't know what patients were receiving. So these additional supplements, patients were receiving either that lutein and zeaxanthin, or the fish oil, or both, or neither, none of them. So we knew everyone was getting the original formula, but were they getting the addition of lutein? Were they getting the addition of the polyunsaturated fatty acids? That's what we did not know. So the results showed that after some careful analysis, the lutein was found to be beneficial. It was not, again, it was only given in 1/4 of the patients that received that lutein alone, but the lutein does seem to be of benefit, and the companies now that make these vitamins, you'll see, are using lutein in their formula. It's an AREDS2 formula. So if you see that on the shelf, that's generally a good idea to go ahead with the lutein, the AREDS2 formula, because the lutein helps, it's beneficial, and it's safer. And so we feel more comfortable using beta-carotene. The reason that it's safer is that in patients that have smoked, even smoked in the past, that beta-carotene gives a slightly higher risk of lung cancer, and we don't exactly know why, but we want to avoid beta-carotene. The polyunsaturated fatty acids that we hear a lot about, the benefits of fish oil for our heart, for stroke prevention, even for dry eye, did not have any effect for macular degeneration. So it's okay to take fish oil. That may be something that you're doing. But in terms of macular degeneration, it's not something that we know of for disease prevention. So AREDS2 formula has the lutein and zeaxanthin instead of the beta-carotene. And just to show you that the beta-carotene in smokers was found in 2 large trials to show an increased risk with lung cancer. So for smokers, they can absolutely not take beta-carotene, and we found that it's safer for the public as a whole to switch out the beta-carotene for the lutein. This just to review, to summarize, that lutein can be used, and that the vitamins, the AREDS2 formula, is useful for patients that have macular degeneration. You might ask, well, my mother has macular degeneration, my father has it, but it is not something that we need to recommend for the patients with, that are relatives, for people who are relatives of patients, or even if you have a very, very mild form of macular degeneration. If you have only one of those yellow spots, you would not need to take this formula. So again, this formula is we advise or we recommend it when we have certain view into the eye that tells us that yes, dry macular degeneration is present. Well, what else do we have in the world of research in wet macular degeneration? So here Dr. Ip has shown you how the revolution has occurred in the last 8 to 10 years for injections. And I just want to ask how many people are getting injections in the audience. There's Got to be a lot of you. So you know what it's like to go through. And it's as Dr. Ip said, it's like a mosquito bite. I'm not sure if that's exactly right, but it is a lot of time and investment on you and your families and friends to make the trip. So we are currently involved in a study for patients that have new onset of the wet macular degeneration. In fact, it has to be new and fairly mild wet form, where we are trying eye drops. That sounds appealing. We're all excited about the idea that there could be an eye drop that may either take the place of the injection or at least allow us to prolong the injection so that there is not so frequent injections. This current study uses eye drops 4 times a day in patients who have just developed wet macular degeneration. If you're already receiving injections, if you've already had wet, we can't enroll you, but this is the first step to see if something that as simple as an eye drop can help patients with wet macular degeneration. And the other work that's being done, the other research, is try to improve the injection process. So if we could have a longer acting medication, that would help. We're now involved at the very beginning of a trial where this new medication could last up to 4 months. This is a medication, doesn't have a name yet, it's just a number because it's being developed by a drug company. And we will start that trial in the next few months where patients with new wet macular degeneration, never had an injection, could get this medication to see if it will last for 4 months. However, with any trial, as you know, even with the eye drops and with the injection, we all have to participate in a masked fashion. That means that when you're in a clinical study, you will not know what you're getting, and I won't know what you're getting, meaning that some portion of the patients will not get the treatment. So in the eye drop study, there can be a portion of patients who will get an eye drop that does not have the medication. In a condition with an injection, there will be a portion of patients that do not get the medication because we don't know yet if it's working. And that's the only way the FDA would allow a new drug to be approved, is if we can compare to the group that does not get the medication and the group that does. So that's the masked fashion that has to be part of all clinical trials. The other type of research that we're conducting is the more severe form of dry macular degeneration. And I know that that was pointed out by Dr. Chandra. Dry can slowly progress to what we call atrophy. And that atrophy can cause you to lose central vision, sort of a cookie cutter patch where you don't see generally right in the center. And we are looking at 2 studies. One is an oral medication where patients are taking a pill 3 times a day to see if that can slow down that atrophy, that thinning of the retina where there's loss of vision in the dry state. This drug is used with the hope of slowing down the metabolism of the cells. We hope that slowing down the metabolism will actually help slow down the degeneration. Again, this is in process. We do have a number of patients that are in this trial, and we will be following them for another year. The other condition, the other type of treatment is intravitreal injections for dry. That's research only. You haven't heard us talk about using injections in dry macular degeneration because that is not a standard treatment. But on an experimental or investigational level, we are now doing injections for patients with atrophy, the severe form of dry. So you'll be hearing more about that. The goal at this point is to preserve as much retina as possible. I don't think this will be the sort of home run that we've seen with the wet form, where we see that injections can get rid of those bubbles. As Dr. Ip mentioned, and to wrap this up, there is research in new ways of delivering medication. And what's exciting here, and there's sort of a cartoon on the left, is that inside the eye, inside that orange cavity, is a white little nubbin, and that's actually a way of delivering medication. It's an implant that allows, with this permeable filter, allows medication to slowly release, a slow release form into the eye. And the other picture shows you the eye fully dilated, and you can see that white rod that allows medication to just percolate into the eye, directly into the eye, without an injection. This could last for up to 3 years. And finally, a very novel and very high-tech type of delivery system is a similar system, an implant that's surgically put into the eye that actually contains cells. And this rod, you see, is the same size as what you saw in the previous slide, but this actually has cells that can secrete medication. We are testing this in a very rare disease that has currently no treatment, but this may be used for macular degeneration as well. So instead of a slow-release medication, it's cells that are actually slowly producing this medication that can be used inside the eye. So in good news, I have shared with you the good news that the AREDS2 formula will help a little bit better than the original AREDS formula to protect the vision that you have and to decrease the risk of developing wet. The good news is that we do have good treatment for wet macular degeneration, no matter what drug, and Dr. Ip talked about the 3 different drugs, but we are still looking for a longer-acting treatment for wet macular degeneration, whether that's through an injection that may last 4 to 6 months or with this implantable device. And we are really at the very beginning of our research in treatment for the dry form of macular degeneration. Thanks so much.